welcome to the deep dive. Today we're taking a look at a set of conditions that, well, maybe aren't household names, but they're really important in vascular health. Vasculitis and other uncommon arteriopathies. So simply put, vasculitis is when your blood vessels get inflamed.
Right.
And this inflammation can damage the vessel walls, mess with blood flow, and potentially cause some serious issues in the tissues those vessels supply.
That's exactly it. And for this deep dive, we've been digging into some really solid material chapters from Rutherford's Vascular Surgery and Endovascular Therapy 10th edition.
Ah, okay. Good source.
Definitely. It's incredibly comprehensive and really highlights just how, intricate and varied these conditions can be. And a key point that jumps out is that vascular surgeons might actually be the first ones to see these patients, even though they're uncommon conditions.
Absolutely. That really struck me, too, reading through this. A vascular surgeon might be the first point of contact. And, like we'll discuss, figuring these out often means teamwork, Bringing in a rheumatologist is often key.
It really is. It takes that collaboration. And to help sort through all this complexity, experts often use the Chapel Hill Consensus Conference nomenclature.
Right, the classification system.
Yeah, basically it groups these disorders based on the size of the blood vessels. They mainly affect large, medium, or small.
Which is helpful
because the vessel size often gives clues about the symptoms and how the disease might behave.
Okay, let's start there then. How does vasculitis generally, show up? Because it's not like one single sign screams vasculitis, is it?
No, not at all. The symptoms really do tend to link up with whether it's the large, medium, or small vessels that are primarily inflamed.
Okay.
So, for instance, if it's large vessel involvement, think aorta, its main branches.
Right.
You might see things like limb claudication, that pain in the legs when walking because blood flow is down.
Makes sense.
Or you might hear vascular brutes, those abnormal whooshing sounds over the vessels, uneven blood pressure between the arms, or even missing pulses in certain areas. Those can also be big clues.
Okay, so major arteries, major impacts on pressure, pulses, that tracks.
Yeah.
What about when it's the medium-sized vessels acting up?
With medium vessels, the signs can look quite different. You might see things like cutaneous nodules, little lumps under the skin, or skin ulcers, sometimes a specific type of rash like a net pattern called levato reticularis,
Okay.
or even, unfortunately, digital gangrene tissue damage in fingers or toes.
Wow.
And neurologically, it can cause something called mononeuritis multiplex, basically damage to several individual nerves, causing weakness or numbness in different spots.
Right, scattered nerve issues.
Exactly. And it can sometimes lead to renovascular hypertension, high blood pressure, because the kidney arteries are narrowed.
And then down to the smallest vessels, what clues do they give?
Small vessel vasculitis often presents with something called palpable purpura.
Palpable purpura.
Like little bruises you can feel. Kind of, yeah. They're small, raised, bruise-like spots. It happens because those tiny inflamed vessels leak blood under the skin.
Got it.
We also see the potential for pulmonary renal syndromes. That's where you get both kidney inflammation, glomerulonephritis, and bleeding in the lungs, alveolar hemorrhage.
That sounds serious.
It can be very serious. Other signs might be hive-like rashes or scleritis, which is inflammation of the white part of the eye.
So a really wide range of symptoms depending on the vessel size. Now, if you actually look at the tissue under a microscope, what's typically seen?
Histologically, you often see the vessel wall infiltrated by different immune cells, neutrophils, mononuclear cells, sometimes giant cells.
Okay.
You might also see fibrinoid necrosis. That's basically the vessel wall breaking down from the inflammation, weakens it.
Right, leading to blockages or aneurysms.
Potentially, yes. And maybe leukocytoclasis, which is broken down white blood cells around the vessels. But it's important just seeing immune cells around a vessel isn't specific enough. That can happen in other things, too.
Okay, so it's the pattern within the wall that counts. The source also mentioned different immune mechanisms involved.
Right. The immune system can mistakenly attack the vessel walls in a few ways. It could be cell-mediated, where T cells directly attack, or immune complex-mediated antibodies and antigens form complexes, deposit in the walls, trigger inflammation.
Okay.
And then there's ANCA-associated vasculitis. ANCA are specific antibodies, anti-neutrophil cytoplasmic antibodies. Think of them as misguided missiles targeting parts of the vessel cells.
Right, the body's own defense system going haywire. Now, beyond symptoms and biopsies, what about imaging? How does that help figure things out?
Imaging is super valuable, especially if a biopsy isn't possible or you need to see how widespread the vessel involvement is.
Like an angiogram.
Angiography, yeah, using contrast dye and x-rays can be really helpful for certain types. But we also have non-invasive tools like ultrasound, MRA, CTA.
Magnetic resonance angiography, computed tomography angiography.
Exactly, and even PET scans. They all give different kinds of information about the vessels and any inflammation.
And what are doctors looking for on those images that screams vasculitis versus, say, just regular atherosclerosis?
Well, characteristic findings might include irregular tapering or narrowing of the vessels, sometimes a beading appearance.
Midbean.
Yeah, like alternating areas of narrowing and slight widening, almost like a string of beads. These patterns can be pretty distinct and help point towards vasculitis.
All right, let's dig into some specific types now, starting with the large vessel ones. First up is giant cell arteritis, GCA, sometimes called temporal arteritis.
That's the one.
Sounds like it hits a specific group of people more often.
It does. GCA primarily affects people over 50, and it's significantly more common in Caucasians of Northern European descent.
Okay.
But, while it's less common elsewhere, you shouldn't dismiss it based just on demographics. Got to look at the whole picture.
Good point.
And interestingly, the chance of getting GCA really goes up with age. Also affects women more often than men.
So, older Caucasian woman, certain symptoms raises a flag. What do we know about what actually causes GCA? Is it known?
The exact trigger, still unknown. But we know genetics play a role. Certain HLA-DRB1 gene variations, like O4 and O1, seem to increase risk. And there's evidence pointing to a T-cell cytokine called IFN gamma. Think of it like a signal ramping up the immune attack on the artery wall.
Okay.
The main idea is some initial immune trigger causes the artery lining to thicken up, which narrows the vessel and cuts down blood flow ischemia.
And what are the classic symptoms that might make a doctor suspect GCA in someone over 50?
The classic picture is a new onset headache, often different or worse than usual headaches,
Right.
along with systemic inflammation signs. About 20% get cranial symptoms like that headache, scalp tenderness, pain when chewing, that's jaw claudication,
Collocation, okay.
or moving the tongue, double vision, even sudden vision loss. New double vision in an older person is a really strong sign. Jaw claudication, too, very specific. And many patients, maybe 40%, also get polymyalgia rheumatica, that pain and stiffness, mostly in the shoulders and hips.
DMR, right.
Yeah.
Yeah.
But sometimes GCA is sneakier, Just fever, fatigue, weight loss, those general systemic symptoms.
So it can be a bit of a diagnostic puzzle sometimes. What about a physical exam? What helps there?
Key things are scalp tenderness when you touch it, and a reduced or tender pulse in the temporal artery on the side of the head.
Okay.
Also important to check blood pressure in both arms. Listen for those roots in the neck and upper chest arteries, because a fair number of GCA patients also have large vessel vasculitis affecting those areas too. And we know GCA significantly bumps up the long-term risk of aortic aneurysms, both thoracic and abdominal. So monitoring the aorta over time is often recommended.
That's a really key point about the aneurysm risk later on. You mentioned blindness too. How does that happen?
Yeah, unfortunately, abrupt, painless blindness can happen in about 15% of patients. It's due to ischemic optic neuritis inflammation cutting off blood supply to the optic nerve.
Oh.
And if someone has a temporary episode of vision loss, like a curtain coming down that's amaurosis fugax, it's a really strong warning sign for permanent blindness later.
Scary.
But the risk of vision loss drops quite a bit once you start steroid treatment. Highlights how urgent diagnosis and treatment are.
Definitely. What about inside the skull? Can GCA affect brain blood vessels?
It's less common. The intracranial vessels lack a specific layer, the internal elastic lamina, but sometimes the internal carotid and vertebral arteries can get involved.
And if they do?
That can lead to serious things like strokes, seizures, hearing loss, vertigo, even cognitive issues or depression.
So potentially severe consequences. How is GCA actually diagnosed? Are there specific criteria?
Yes. The American College of Rheumatology put out criteria back in 1990.
Okay.
Basically, age over 50 at onset, new headache, temporal artery abnormality like tenderness or reduced pulse, a high ESR.
Erythrocyte sedimentation rate, that inflammation marker.
Right, and an abnormal artery biopsy showing vasculitis. If you meet 3 out of those 5, it strongly suggests GCA. And you often see other inflammation signs in blood tests too, like high CRP, a specific type of anemia called normocytic anemia, and high platelets.
And the temporal artery biopsy, you said that's the gold standard. What are they looking for exactly?
Ideally, you want a decent length sample, maybe 2 to 3 centimeters. Some recommend bilateral biopsies if the first is negative because the inflammation can be patchy.
Why, skip lesions?
Exactly. They're looking for a lymphocytic, infiltrate-specific white blood cells and often granulomatous inflammation with those giant cells.
Okay.
But, important note, sometimes you only see the lymphocytes, no giant cells. And fragmentation of that internal elastic lamina layer, that can happen with aging, so it only really counts if there's inflammation too.
Timing matters too, right, with steroids?
Ideally, yes, best before steroids or within about a week after starting. Steroids can dampen the inflammation signs, but even if steroids have been started, sometimes you can still see signs of healed temporal arteritis like scarring and fibrosis.
What about imaging for the larger vessels in GCA?
Mm.
Angiography.
Yeah, conventional angiography, MRA, CTA, they can all assess the aorta and its main branches.
Okay.
Newer things like ultrasound of the temporal arteries can show inflammatory wall changes, maybe even guide the biopsy location, but it shouldn't replace the biopsy.
Right.
And PET scans can show increased activity in the aorta walls, suggesting inflammation, but it's not quite standard everywhere yet.
And finally, treatment. How do you manage GCA to prevent those awful complications?
Corticosteroids are the cornerstone.
Mm-hmm.
Usually start with a high dose, like 40 to 60 milligrams of prednisone daily.
Okay.
If someone's at high risk of vision loss, maybe IV methylprednisolone for a few days first to hit it hard.
Right.
Then you keep the high oral dose until symptoms improve and inflammation markers normalize, usually at least a month. After that, it's a long, slow taper, often over a year or two.
Wow, long time.
Yeah, and you have to watch symptoms and markers closely with each dose drop because relapses are really common. Many patients, especially women, end up needing long-term low-dose steroids. Low-dose aspirin is also usually recommended to cut down cardiovascular and blindness risk.
Any newer options?
Yes. Tocilizumab, it blocks an inflammatory protein called IL-6. It's shown real promise for reducing steroid needs and preventing relapses.
That's good news.
Definitely. And other trials are ongoing. Surgery, rarely needed for the narrowing itself because the body often builds collateral vessels. Angioplasty has a high risk of re-narrowing unless the inflammation's controlled.
But for the aneurysms?
Right, surgery is indicated for the aortic aneurysms that can develop later on. Outcomes are generally similar to surgery for other aneurysm causes.
Okay, let's move on to some other large vessel conditions. The source mentions idiopathic aortitis. What's that?
It basically means inflammation of the aorta where the cause isn't obvious. Sometimes it's found incidentally during aneurysm repair surgery, seen in a small percentage of those cases. If it's in the thoracic aorta, sometimes it looks like GCA under the microscope, other times different. Interestingly, a good chunk of thoracic idiopathic aortitis cases are linked to IgG4-related disease, which we'll get to.
Okay.
In the abdominal aorta, inflammation found during repair might be related to idiopathic retroperitoneal fibrosis or inflammatory aneurysms often linked to smoking and family history, or again, sometimes IgG4 disease.
And that leads into idiopathic retroperitoneal fibrosis or Orman disease. Sounds specific.
It is. Rare condition. You get excessive fibrous tissue building up behind the abdominal cavity, the retroperitoneal space.
Okay.
It surrounds the aorta, kidneys, ureters. Tends to affect middle-aged men more.
What are the symptoms?
Usually a dull, aching pain, low back, abdomen, flanks, maybe fever, weight loss. High blood pressure is common, leg swelling too from vein compression. Blood tests aren't super helpful, but inflammation markers like ESR, CRP are often up.
And imaging?
CT scan is key. Shows this soft tissue mass wrapping around the aorta and iliac arteries, often pushes the ureters aside, can block them, causing kidney swelling, hydronephrosis.
What?
Biopsy shows dense fibrous tissue, immune cells, the cause. Not fully known. Maybe an inflammatory reaction to oxidized LDL cholesterol and aortic plaque.
How was it treated?
Usually high-dose prednisone first, then a very slow taper over months. Often need low-dose maintenance therapy for a year or two to prevent recurrence.
Recurrence is common then.
Yeah, risk is significant. Other immunosuppressants might be used if steroids don't work well or they relapse. Needs close monitoring with scans and blood tests.
You've mentioned IgG4-related systemic disease a couple of times now. What defines that one?
Right. Tends to affect older men, often with allergy histories. Hallmark is these tumor-like lesions in various organs.
Okay.
Microscopically, you see dense immune cell infiltrates, lots of fibrosis or scarring, and vein inflammation phlebitis. Key diagnostic feature. The tissue stains positive for lots of IgG4 antibodies. Serum IgG4 levels are often high too, but not always.
What organs does it hit?
Can be many. Autoimmune pancreatitis, bile duct inflammation, sclerosing cholangitis, swollen salivary glands are common.
And the vascular connection.
Right, it can cause aortitis and aortic aneurysms, more often thoracic. Can sometimes look like retroperitoneal fibrosis. Treatment involves steroids, other immunosuppressants, maybe rituximab, which targets B cells.
And the last large vessel one mentioned was Erdheim-Chester disease. Sounds very rare.
Extremely rare. It's a histiocytic disease, abnormal proliferation of immune cells called histiocytes.
Okay.
Characterized by fibrosis around the aorta, sometimes called a coated aorta on scans. Also infiltration of coronary arteries, thickening of the heart sac, pericardium.
How is it different from RPF or IgG4?
It can look similar, involving the retroperitoneum, the hairy kidney appearance sometimes. But a key difference. Most Erdheim-Chester patients also get bone lesions, often in the legs, causing joint pain.
Ah, the bone lesions, exactly.
Biopsy shows specific foamy histiocytes, giant cells. And interestingly, it's often linked to a specific gene mutation, BRAF V600E.
Does that help remit?
Hugely. Drugs targeting that BRAF mutation are very effective.
Okay, fascinating. Let's switch gears now to medium-sized vessel vasculitis, starting with polyarteritis nodosa, or PAN. What sets this one apart?
PAN is a necrotizing vasculitis, causes tissue death affecting small and medium arteries. Key distinguishing features. It doesn't cause glomerulonephritis, that kidney filter inflammation.
Right.
And it's not associated with those ANCA antibodies. Diagnosis often uses ACR criteria, need 3 out of 10 specific findings.
What causes PAN? Any known triggers?
Often it's idiopathic, we don't know the cause.
Right.
But sometimes it's secondary to chronic hepatitis B infection.
Type of H.
Yeah, usually develops about 7 months after the initial hepatitis diagnosis in those cases, less often linked to HIV or certain blood cancers.
And under the microscope, what does PAN look like in the vessel wall?
It's a focal, segmental necrotizing vasculitis, meaning it hits specific segments, not the whole circumference or length uniformly. Affects medium arteries, often down to smaller arterioles, but usually spares the big arteries and veins. You see fibrinoid necrosis, damage to the middle layer, with neutrophils and lymphocytes infiltrating.
Right.
And you might see active new inflammation right next to older healed lesions. Shows it can be relapsing, remitting.
Okay.
This damage weakens the wall, can lead to aneurysms, or cause clots, thrombi that block flow and cause tissue damage downstream.
So no single blood test diagnoses it, but what do labs typically show?
Correct. No specific diagnostic test.
Oh.
But you often see high inflammation markers, ESR, CRP, maybe that normocytic anemia, again, high platelets. Complement levels are usually normal.
You test for Hep B.
Absolutely crucial. If it is Hep B associated, you'll see evidence of the virus.
Mm.
Importantly, ANCA tests, rheumatoid factor, cryoglobulins, ANA, those are usually negative in classic PAN.
Okay. Clinically, how does PAN present? What symptoms suggest it?
It's really varied because it can hit different organs, often constitutional stuff, fever, fatigue, weight loss. Skin lesions are common, that palpable purpura, levato-reticularis rash, necrotic lesions, digital infarcts.
Right.
Peripheral neuropathy, often that mononeuritis multiplex pattern is common too. Lots of patients get bad abdominal pain from mesenteric artery vasculitis supplying the gut.
Gut ischemia is a big worry then.
Major concern, yes. Bowel ischemia, even perforation. High blood pressure, kidney signs like blood or protein in urine can happen too.
So biopsy is key.
Biopsy of affected tissue, if possible, is really key. If symptoms point to gut or kidney vessel issues, an angiogram can be very helpful. It might show those classic saccular aneurysms, microaneurysms, narrowing, blockages.
Interesting that a kidney biopsy isn't always helpful, though.
Right, because the main damage isn't usually in the glomeruli themselves in PAN, though sometimes small renal artery aneurysms can rupture and bleed.
What about lungs?
Muscle aches, joint pains are common. But importantly, classic PAN doesn't typically hit the lungs or upper respiratory tract. That helps distinguish it from some ANCA vasculitides.
Okay. How is PAN treated? Does it differ if it's linked to Hep B?
Yes, definitely differs. If it's Hep B associated, priority 1 is antiviral therapy for the Hep B.
Makes sense.
In severe Hep B PAN cases, maybe short-term steroids and plasma exchange as a bridge until antivirals kick in. But you generally avoid long-term immunosuppression there.
And for non-viral PAN?
Goal is immunosuppression. Steroids, like prednisone, are key and have massively improved survival.
Right.
For milder disease, maybe just steroids, tapered slowly. If that's not enough or disease is more severe, might add azathioprine or methotrexate.
And for moderate to severe pan.
Then initial induction therapy is usually high-dose steroids plus cyclophosphamide, followed by maintenance with azathioprine or methotrexate to prevent relapse.
Cyclophosphamide, that's the heavy hitter, right?
It is. Need rheumatology involved,
Uh-huh.
potential side effects, low blood counts, fertility issues, bladder problems, long-term cancer risk. Dose needs careful adjustment,
Mm-hmm.
and patients on this level of immunosuppression usually need PJP pneumonia prevention.
Got it. What's the long-term outlook for pan?
Untreated, prognosis is poor, but with treatment, 5-year survival is much, much better. Worse outlook if older, 65, serious heart or GI involvement, or existing kidney problems. Kidney transplant outcomes are tougher than for other causes, higher recurrence risk.
This source also mentioned other things causing visceral aneurysms that could mimic pan.
Right, briefly. Segmental arterial medialysis, SAM, that's non-inflammatory, affects muscular arteries, can rupture causing bleeds. Different pattern than pan.
Okay.
Also some inherited connective tissue disorders, pseudocanthoma elasticum, neurofibromatosis type 1, vascular Ehlers-Danlos, weakened vessel walls, and a rare genetic enzyme deficiency, adenosine deaminase 2, can look like pan too.
Let's move to thromboangiitis obliterans Berger disease. This one is all about tobacco, isn't it?
Absolutely. The link is incredibly strong. It's an inflammatory condition blocking small medium arteries, veins, even nerves in the limbs. The inflammation is maybe milder than some others we've discussed.
And the tobacco connection is key.
It is the key. Almost exclusively affects young men, 1850. More common in Middle East, Far East. Exceptionally strong link to all forms of tobacco, cigarettes, pipes, marijuana, smokeless.
What symptoms point towards Berger's in a young smoker?
Often starts with claudication, specifically in the foot arch or instep sometimes.
Specific location.
Yeah, can progress to severe finger-toe pain, gangrene, ulcers, rest pain, often triggered by minor trauma.
Okay.
Superficial thrombophlebitis, those tender red cords under the skin, is common. Raynaud's phenomenon too, finger stows changing color and cold.
How's it diagnosed then, if it mimics other things?
It's mainly a diagnosis of exclusion. Rule out clots from other causes, diabetes, autoimmune diseases, atherosclerosis, endocarditis.
Right.
Arteriography is key, shows characteristic features,
Right.
bilateral focal segments of narrowing blockage in distal limb arteries, normal vessels in between.
Uh-huh.
And you see these distinctive tree root or corkscrew collateral vessels trying to bypass the blockages. Crucially, the bigger proximal arteries look normal. No atherosclerosis, no emboli source.
And what does the pathology show? In amputated limbs, for instance.
Yeah, that's where most info comes from. Shows panvasculitis inflammation of all layers with a very cellular clot, maybe microabscesses.
Okay.
In less acute stages, the clot is less cellular, maybe starting to recanalize. A key difference from other vasculitis: the internal elastic lamina is usually intact. Vein inflammation, venulitis, is also common.
And treatment? You said tobacco is key.
Absolutely critical.
Yeah.
Total permanent tobacco nicotine cessation, all forms. No nicotine replacement either.
Got it. Anything else help?
Calcium channel blockers, pentoxifylline sometimes help blood flow. 4V, iloprost for critical limb ischemia. Sympathectomy might be considered for pain vasoconstriction.
But prognosis depends on smoking.
Heavily. About half who keep smoking eventually need amputation. Bypass surgery is tough because the disease is so distal, but there's some promise in patients who completely quit nicotine.
Last medium vessel 1, Kawasaki disease. That's kids, right?
Yes, primarily infants and young children, usually under 5. Acute vasculitis, small medium arteries, has a real liking for the coronary arteries.
The heart arteries.
Exactly. High persistent fever is the main sign, plus rash, red eyes, mouth changes, swollen nodes.
And the danger is the coronary arteries.
Right. Risk of dilation or aneurysms in untreated kids can lead to heart attacks later. Prompt treatment with high-dose aspirin and IVG drastically reduces that risk.
Okay. Worth mentioning MISC, too.
Yes. Multisystem inflammatory syndrome in children, seen after SARS-CoV-2, can share some features with Kawasaki.
All right, let's move to the small vessel vasculitides now, starting with ANCA-associated vasculitis, AAV, linked by those ANCA antibodies.
Correct. Group affecting small arteries, capillaries, venules, linked to those autoantibodies targeting neutrophil proteins, main types, GPA, MPA, and EGPA.
GPA granulomatosis with polyangiitis, formerly Wegener's. What defines it?
Characterized by granulomatous inflammation, that specific immune cell pattern. hits upper respiratory tract, sinuses, nose, throat, lower respiratory tract, lungs, and causes post-immune glomerulonephritis.
Post-immune meaning few immune deposits in the kidney.
Exactly. Strong link to Trianaceae, usually targeting PR3 protein, can be generalized, respiratory plus kidney, or limited, just respiratory. Rare, more in Caucasians, mean age around 41.
What symptoms suggest GPA?
Often persistent upper respiratory stuff. Chronic sinusitis, nosebleeds, nasal discharge. Chronic ear infections, new onset in an adult, is a clue. Hoarseness from larynx trachea inflammation, subglottic stenosis, airway narrowing. Nerve issues like mononeuritis multiplex, sometimes CNS involvement like pachymeningitis, lungs, very common, nodules, infiltrates on imaging, pulmonary capillaritis, bleeding in lung vessels can happen, and the kidney involvement, that post-immune crescentic GN, can cause rapid kidney failure.
What about labs? ANCA always positive.
Usually positive in generalized GPA, especially CHAN-CKPR3, highly suggestive. Can be negative, especially in limited forms. Urinalysis is crucial for kidney signs. ANCA levels or titers sometimes track disease activity. Rising titer might predict a flare. PR3 positive patients have higher relapse risk if maintenance therapy stops.
How's GPA treated?
Several generalized cases. Induction with high-dose IV steroids, then oral taper. Plus rituximab or monthly IV cyclophosphamide. Plasmapheresis if there's severe lung bleeding. Rituximab is as good as cyclophosphamide for induction, maybe better for relapse.
What about limited GPA?
Prednisone plus methotrexate might be an option if kidney function is normal.
And long-term?
Maintenance therapy is key to prevent relapses. Azathioprine works, but rituximab might be better, especially for PR3 positive patients, often need maintenance for years, plus PJP prevention, osteoporosis monitoring, watching for cyclophosphamide side effects.
Next is microscopic polyangiitis, MPA. How's it different from GPA?
Also, systemic necrotizing vasculitis of small vessels, ANCA associated. But key differences: post-immune, few deposits, and no granulomas like GPA. Affects men, women, often age 30-50.
And main clinical features of MPA?
Most common, most serious, is pulmonary renal syndrome. Rapidly progressive glomerulonephritis in nearly all, plus pulmonary capillaritis, lung hemorrhage in about a third.
ANCA pattern in MPA.
More often PANCA with MPO specificity, though some have CAN-CKPR3. If PR3 is positive, lack of upper respiratory symptoms helps distinguish from GPA.
Biopsies, what do they show?
Kidney, focal segmental necrotizing GN with crescents, post-immune, lung, capillaritis, usually negative immunofluorescence. Skin might show leukocytoclastic vasculitis.
Treatment similar to GPA EGD.
Yes, induction is similar. High-dose IV steroids, oral taper, plus cyclophosphamide or rituximab, maybe plasmapheresis for acute lung hemorrhage. Maintenance also similar. Prognosis can be guarded, high relapse dialysis risk. 5-year survival around 70-75%.
Finally, in AAV, eosinophilic granulomatosis with polyangiitis eGPA. Churg-Strauss. This one leads to allergies, asthma.
Yeah, absolutely. Rare granulomatous vasculitis, small medium vessels, characterized by high eosinophils in blood tissue, very strong history of allergic rhinitis polyps, and adult onset asthma usually present. ACR criteria include asthma, high eosinophils, 10%, neuropathy, lung infiltrates, sinus issues, eosinophilic biopsy. Need 4 criteria.
What's the underlying process?
Hallmark is extravascular necrotizing granulomas, often with an eosinophil-rich core, driven largely by cytokines like IL-5, which boosts the eosinophils. There's been some talk about leukotriene inhibitors used for asthma, maybe unmasking eGPA when steroids are reduced.
How does eGPA typically present?
Often described in 3 phases, though not always distinct. Prodromal phase. Years of rhinitis, asthma, polyps, fevers. Eosinophilic phase. High eosinophils in blood tissue can cause shifting lung infiltrates, eosinophilic pneumonia, or gastroenteritis, myocarditis. Then the vasculitic phase, years after prodrome starts. Asthma might actually improve here. Vasculitis hits multiple organs, heart, nerves, neuropathy, gut, skin, purpura, testicular pain.
Lab findings. High eosinophils, obviously.
Yes. Mark eosinophilia, often 1500. Serology often shows pan-campo, but some are ANCA negative. ANC positivity linked more to kidney disease, hemorrhage, neuropathy, purpura. Might have positive rheumatoid factor, too.
And treatment for eGPA?
Usually high-dose IV steroids initially, then oral prednisone, maybe monthly IV cyclophosphamide for severe cases.
Any targeted therapy?
Yes, mepolizumab. It's an anti-IL-5 antibody. It reduces eosinophils. Approved as a steroid-sparing agent, helps cut relapses and steroid need.
Okay, let's shift to vasculitis secondary to other connective tissue diseases. First, Beset disease, What are the vascular issues there?
Behçet's is a systemic vasculitis, unknown cause. Classic triad, oral genital ulcers, uveitis, eye inflammation. But vascular involvement is common, especially in young men.
Arterial and venous.
Both. Thrombosis, clots in arteries and veins, and unusual aneurysms, pulmonary artery aneurysms, are a known complication.
Okay.
High risk of DVT, SVT in limbs, also clots in big central veins, but Chiari, hepatic, mesenteric, renal, intracranial. Clots tend to stick to the wall, can progress despite anticoagulation.
What about arteries?
Less common than venous, but can get occlusive disease, and aneurysms aorta most common. High risk of rupture, thrombosis, recurrence after repair. Pulmonary artery aneurysms can cause fatal lung bleeds. Even line insertion carries risk of aneurysm formation at puncture sites.
Sounds like complex management. How's it treated?
Focus is immunosuppression, steroids for flares, DARDs like azathioprim, methotrexate, cyclosporine for long-term, colchicine for ulcers, thalidomide for refractory ulcers.
I'm for the vascular parts.
Higher dose steroids, cytotoxic agents like cyclophosphamide might be needed. Relapses are frequent, needs close monitoring.
What about systemic lupus erythematosus, SLE? Can that cause vasculitis too?
Yes, vasculitis happens in up to a third of SLE patients. Most common is small vessel skin vasculitis, leukocytoclastic type. Can cause tender dots, ischemic lesions, nodules, ulcers. Medium vessel can occur too, mononeuritis multiplex, visceral organ involvement. Even large vessel, Takayasu-like, is reported.
Any particularly dangerous type?
Pulmonary capillaritis can cause alveolar hemorrhage, high mortality. Inflammatory vasculitis in SLE usually needs escalated therapy, more steroids, immunosuppressants.
Important point about antiphospholipid syndrome.
Right. Need to consider that in SLE, patients with vascular events like ulcers. It can mimic vasculitis but needs anticoagulation and hydroxychloroquine.
Rheumatoid vasculitis,
Yeah.
linked to long-standing RA.
Yes, a serious but less common complication of long-standing, often aggressive RA, usually with high rheumatoid factor.
How does it manifest?
Cutaneous ulcers, peripheral neuropathy, scleritis, rarely mesenteric or aortic involvement, high morbidity mortality, needs aggressive treatment, high-dose steroids, potent biologic DMARDs.
Briefly, relapsing polychondritis and Cogan syndrome. Vascular links.
Relapsing polychondritis, rare autoimmune, inflames cartilage, ears, nose, trachea, can involve large vessels aortitis, aortic aneurysms. Cogan syndrome, also rare, immune-mediated. Can have large medium vessel vasculitis like Takayasu. Classic features are interstitial keratitis, eye and audiovestibular problems, vertigo, hearing loss, developing close together. Needs steroids, maybe other immunosuppressants for systemic vestibular issues.
And pseudoxanthoma elasticum and exercise-related external iliac arteriopathy. Are they vasculitis?
Not exactly inflammatory vasculitis. Pseudoxanthoma elasticum is inherited, causes abnormal elastic tissue buildup in arteries, leads to early diffuse arteriopathy, claudication, needs screening for coronary disease, higher bleed risk with antiplatelets.
Right.
Exercise-related external iliac arteriopathy seen in competitive cyclists. Repetitive compression causes non-inflammatory fibrosis thickening of the artery wall. Leads to stenosis, occlusion, exercise-related claudication. Treatment can be bypass, endarterectomy with patch, or stenting.
Finally, the source mentions vasculitis mimics things that look like it but aren't primarily inflammatory. Can you highlight those?
Sure. Fibromuscular dysplasia, non-inflammatory, often renal carotid but can be anywhere. Always consider it for non-inflammatory lesions.
Okay.
Radiation arteritis, inflammation fibrosis in arteries after radiation therapy for cancer, can cause stenosis or aneurysms, sometimes decades later. Carotids often affected. Looks like accelerated atherosclerosis but in unusual spots, or tapered narrowing like GCA. Endovascular treatment is common due to poor surgical healing, though restenosis risk might be higher than for atherosclerosis. Neurofibromatosis type 1, NF1 genetic disorder. Mainly tumors, but rare vascular issues can occur, resembling FMD in young people, aneurysms, stenosis, AVMs. Risk of spontaneous rupture. Surgery is usually effective.
And drug-induced.
Important category. Various drugs, chemo, growth factors, interferons, some diuretics, antibiotics, others can trigger hypersensitivity vasculitis. Beta blockers can worsen Raynaud's. Ergot drugs for migraine can cause vasospasm, clots mimicking Takayasu, cocaine clots, dissection, stroke. And levamisole adulterated cocaine causes a nasty skin vasculitis, necrotic, cookie-cutter lesions. Treatment is stopping the drug, wound care, maybe immunosuppression if severe.
This has been an incredibly thorough, really detailed deep dive into a complex area. To wrap things up, what are the key takeaways for our listeners?
Yeah, it's a lot. I think the main thing is that vasculitis and these uncommon arteriopathies cover a huge spectrum.
Right.
And the critical point is they show up in so many different ways. They often mimic more common things like atherosclerosis or blood clots.
So you need a careful look at everything.
Absolutely. A comprehensive evaluation, clinical picture, lab tests, imaging results is essential to get the diagnosis right.
And it sounds like keeping these less common conditions in mind is crucial, especially when someone has vascular symptoms but lacks the usual risk factors like smoking or high cholesterol.
That's precisely it. In those cases, you really have to think beyond the usual suspects and consider if there's an underlying vasculitis or arteriopathy going on.
So reflecting on all this, the diverse triggers, the varied presentations, it really makes you wonder, doesn't it? With advances in personalized medicine, genetic testing, how might those help us understand these complex vascular disorders better? Could they lead to more targeted, more effective ways to diagnose and manage them down the road? It's definitely a fascinating area to watch.
It really is. The potential to tailor diagnostics and treatments based on an individual's specific disease and genetic makeup, that holds tremendous promise for improving outcomes in these challenging conditions.